So if you test them and they don't respond, you don't find a direction of preference, then you would try to just give exercise to slowly get the tissue used to the movement and all of that. Or would you go ahead and try to do some mobilizations or try both and see what works? What usually is your rationale of the treatment if they don't respond to the repetitive movements?
Yeah, absolutely. And so those repetitive movements would be at the MTP joints, right? Most often as a referred pain. From some of the work that I did with the fellowship training up at Damon College, we go a little bit more in depth with some ankle specific mobilizations, or maybe kind of revisiting probably some things that I had forgotten through some of my MDT training process, kind of moved away from that. So kind of moved back in that direction a little bit more, looking at your talar mobilizations, looking at the midfoot, inversion, eversion, looking at your cuboid and navicular mobility. One patient in particular that I treated probably about 4 or 5 months ago actually was having her plantar foot pain referred from her cuboid, which was kind of a familiar pain reproduction when I was mobilizing kind of that lateral midfoot. So a lot of that clinical decision making is just made based on their other mobility. So are you looking at, the soleus length or the ankle dorsiflexion flexibility relative to what's necessary? There's some good research that looks at leg stiffness, and this is a weight-bearing problem, so you'll see runners with this. It looks at leg stiffness predictors and found that ankle dorsiflexion mobility and great toe extension mobility were your greatest predictors for increased leg stiffness when running. So that's my own personal bias, and I'll double check and make sure that the mobility there, the great toe extension, and the ankle dorsiflexion is enough to complete the functional task. So use your own clinical judgment from that perspective. Yeah. But I definitely try to pair those with functional mobility exercises. And again, trying to look for other forms of a response-based assessment that's not specific to repeated movements of just the metatarsal phalangeal joints. You can still get a patient to walk and mobilize their ankle and, have them retest whatever baseline and, see if there's any change.